We're at CRT 2014, and there are a pair of papers coming up in JACC, and I want to talk about the stratification of outcomes after TAVR according to surgical inoperability, technical versus clinical reasons, and sex-related differences in outcomes after TAVR. And I'm with David J. Cohen, who is the Director of Cardiovascular Research at St. Luke's Mid-America Heart Institute. Now, in the first one, let's talk about the one where we're looking at inoperability versus technical reasons, which have to do with the procedures itself or the patient procedures, or patient variables, such as, I would imagine, comorbidities, right?
Exactly. So this is an analysis that Raj Makar from Cedars-Sinai led from the Partner B trial. So these were the inoperable patients. Okay. And recall that there were two ways that a patient could be inoperable. They could be technically inoperable, which meant there was some anatomic issue. Porcelain aorta, previous chest irradiation, other sorts of things that would, hostile chest, things that precluded a safe surgical approach. And then there was a second group of reasons, which were patients who were too sick. Patients whose anatomy was just fine, but they had very bad lung disease, they were very frail, they were very elderly, renal insufficiency, all of the things that really factor into the STS risk score for that. And so both groups of patients were represented in the Partner B trial, which overall showed a survival advantage, as you know, compared with conventional medical therapy for these patients with AS. And so what this study did was to separate those two groups of patients and to look at them in terms of the absolute benefit achieved. And what they saw was that both groups benefited from TAVR, regardless of the reason for inoperability. But the benefit was far greater, both in terms of survival advantage at a year and 2 years, as well as the quality of life advantage at 2 years in the patients who were technically inoperable. And again, that makes sense because the technically inoperable group, if you actually looked at their STS risk scores, these were the group of patients in Partner B whose STS risk was 2, 3, 4%. They were very normal operative risks if you could only get them through the procedure. And that's what the TAVR allowed them to do. In the clinically inoperable group, again, a sicker group of patients in general, a group that we still struggle a little bit in terms of the evaluation, but it was reassuring that even in that group of patients, when they were appropriately selected as they were in the Partner trial, there was still a benefit, but it was substantially smaller than in the technically inoperable group.
Now, in the other paper, which is also a Partner sub-analysis, I believe, taking a look at sex and its relationship to outcomes.
Yes, so this is analogous in some ways and different. So the main way that it's different from the study we were just talking about is this was an analysis that focused on Partner A, looking at patients who were getting surgery, or surgical aortic valve replacement, or transcatheter aortic valve replacement. And the idea here is we know that sex, female sex in particular, is a risk factor for adverse outcomes with cardiac surgery, especially aortic valve replacement. It's one of the very important risk factors. And so what was done was simply the patients in Partner A were segregated, the men and the women, and looked at the long-term outcomes. And they were actually quite different. So in the women, there was essentially a survival advantage. It was borderline, but it was very clear that survival advantage was there early, and it actually widened out to a somewhat later time point. With the men, there was a trend towards an early survival advantage, but by a year it was gone. And so I think the message here is that a particular group of patients who really benefit from TAVR are high-risk women. They really do seem to benefit, and I think, again, if you talk to surgeons, they recognize there are differences in the way that men and women recover from this procedure, and that's why female sex is actually a risk factor in the STS risk score. So, again, the women, we can think of it's almost, there are a group of patients who, if you can get them through the operation, they do great. The men, their risk score was high, and their risk was high because of comorbidities. The men were just a sicker group of patients in general. The women were healthier, other than just being women. And so the men, their comorbidities caught up with them, so there was no survival advantage at a year. But again, women, in my view, are a group that is really well served by TAVR.
And both of these papers are coming up in the Journal of the American College of Cardiology. Right now they're online before print, and you will find the citations for both of these coming up right after I say, I'm Rick McGuire, Executive Editor of CardioSource World News.